It's ready.
Great. Hi, everyone. My name is Alison Murphy. I'm a PhD candidate from Penn State University. I work with Dr. Madhu Reddy, who's also part of the College of Information Sciences and Technology here at Penn State. And this research study also includes Dr. Jennifer Kraschnewski, who's from Penn State Hershey Medical Center. I'm excited to talk to you today about our research study, which is currently ongoing. And it looks at identification and management of patient information problems during morning rounds. Introduce this topic and provide some context. I'd like to just talk about hospital work in general. So those that work in hospitals or do research in hospitals understand that hospital work is highly collaborative. So individuals on patient care teams are very much dependent on each other to provide information and to make sure that their patient care tasks get done because they're all dependent on one another. And this includes individuals like physicians, nurses, care coordinators, social workers, therapists, pharmacists, and other clinical and non-clinical individuals. So because patient care teams are so highly dependent on each other to provide accurate and updated information so that they can make these informed decisions about patient care and to make sure that their patient care tasks can be completed effectively. However, there's still problems that occur with patient information, and these just exist in the hospitals. They can have a negative effect on patient care experience. However, we know they can also just be an inherent part of hospital work. And when I talk about patient information problems, or what I'll refer to as PIPs in this presentation, is what we've been issues related to clinical patient information that impacts the patient care team's ability to perform work. So this includes addition, electronic health record system in order to look at a patient's medicine list for their active medications, and it may be outdated, or there may be wrong medications listed in there. So this would be an example of an information problem. Another information problem may be a nurse who's tasked with giving a patient a blood transfusion, and perhaps the blood type is not listed. It's missing from the patient's record in the EHR system. And so therefore would be missing patient information that can cause her additional work and impact her patient tasks. So there, since patient information problems are such an important part of hospital work, they just exist and they can have an just impact on the patient care teams themselves and the patient. We wanted to look in the background to see what's currently being studied about patient information problems. And we specifically looked in the domains of medical informatics, which is more practitioner-based, looking at the hospital work itself, as well as interaction, which looks at the technical side of designing systems that help users more effectively conduct their work. The literature was that a lot of studies around the causes of PIPs, which is very important because if we can understand what's causing them, we can hopefully help prevent or at least mitigate the impacts that occur. And so we're looking at a more technical domain. There were really two main causes that were talked about by prior research. The first is health record system design. So just the way that systems are designed can sometimes lead to information problems. One example of this would be the fact that sometimes in drop-down values, one example that I saw in my own study was when physicians are trying to select medication for a patient. And some medication names are very long, or they include additional information such as the form, whether it's a tablet or capsule or liquid. And the string of information is so long that it sometimes gets truncated by the screen. And so the physician selecting that medication can't always see all of the information. So this would then present information problem. Therefore, they may actually select the wrong information because of this. The second researchers talk about was the EHR user themselves, which is simply the fact that sometimes people enter the wrong information. Either they're incorrect information or sometimes they use a copy and paste function when trying to make their work more efficient, and they'll copy something from one patient's record into another patient's record and try and change some of the things that are applicable to that record, but not everything is changed. And then what this does is it creates a persistent problem that gets carried through other patient records. An example given by the literature with EHR users is that at times, just simply due to the sheer amount of work that needs to be done by clinicians, that they're very busy and they don't always have time to immediately update the formal record, which in most cases would be the electronic health record. So it leaves the system outdated for a period of time, which impacts anybody else that's relying on that particular information to do their work. This is what a lot of researchers talk about were the impacts of patient problems. And these, obviously, when they encounter a problem, it requires a lot of additional work for them to fix it, or at least to figure out if it is, in fact, wrong information or outdated information. Other times can actually lead to confusion about what treatments or procedures were done to patients. And throughout the process of additional work and confusion about treatments, this then leads to our third point, which is delayed patient care decisions. The research spoke about having to work through all of these patient information problems, delay their ability to make decisions about treatment, about diagnosis, or even about discharge. And then finally, if the patient information problems are not even identified, if there's wrong or outdated information, the person using that information doesn't realize it's wrong or outdated, decisions can be made that can then lead to medical errors that can harm patients. So they understand what current research is going on in the field of patient information problems. We have certain research motivations, certain aspects that really motivate our own research in this project. So that we notice current research focuses on the causes and impacts of PIPs, but there's general taxonomy that helps us classify the types of PIPs. What we mean by this is a lot of times they would mention that there was wrong information or inaccurate or something was missing, but we really don't know the entire scope of what are all of the different types of information problems occurring, and how do we kind of define mutually bound those different types. And what this do is it can help better inform design of systems if we're aware of all the different types, as well as make the patient teams more aware of the types of issues that can occur with their information. And so this leads to our first research objective, which is to create a PIP taxonomy. The second phase of our research is we saw that there was a limited understanding of how PIPs are actually identified and managed. So it was talked a lot in terms of how they were actually caused, which is important, but the fact is they still exist. There's going to be at times wrong information or outdated or missing information. So we like to know how the patient care, who's so highly collaborative and very mobile and tasked with doing a lot of different things at once, when they identify that there actually is an information problem, how do they know that it's an information problem? And then what do they do about it afterwards? So how do they go about managing it? So our second research objective is to describe how PIPs are actually identified and managed so we can better understand that process. And then finally, as we know, the HITECH Act, especially here in the United States, there's been a rapid implementation of electronic health record systems. So the transition from paper-based patient records to EHR, electronic records. And this does, as studies show, change how patient care teams enter, view, and share information. And so want to understand the role that technology plays in this. So how including a system change the way in which information problems are identified and managed, and can we possibly improve the design of these systems? Our third objective, to provide improvements for the HR design to better help facilitate this collaborative patient care team's ability to identify and manage these information problems. So now that I've touched on our study and our objective, I'll walk through our methodology, which is how we conducted our study. So our study was, I conducted a qualitative research in an inpatient area of a large teaching hospital here in Pennsylvania, and I shadowed 5 internal medicine teams during rounds. So here are the 116 individuals that I observed, and I primarily followed around these internal medicine teams, which had one attending physician, and they had a number of medical residents and medical interns as a part of that team. And then throughout the process of morning rounds, their interaction with a lot of other members of the patient care team, including, as listed here, nurses, consulting physicians, such as individual from cardiology or neurology that had to consult on the patient, as therapists, occupational therapists and physical therapists, care coordinators, social workers, and we also had some pharmacists that rounded with our team. The way in which I collected data, as I mentioned, was a qualitative study, so we employed qualitative methods of doing an observation of 29 morning rounds. And this was 155 hours of observations over the course of 3 months. And just to be specific about the activities that I observed, I went very early with the residents to watch the handoff discussions that occurred between night flow and the day shift. And then with the residents and interns during their pre-rounds, where they visited all of their patients that they were responsible for, see preliminary information as those patients woke up and their vitals from the nurses. And then we met back in the resident workroom with them, and then we went on our full rounds with the entire team, which typically included visiting anywhere from 12 to 16 patients throughout various units within the hospital. I went back to the resident workroom and watched their EHR documentation process, And we also went to the emergency department when there were new inpatient admissions to watch that transfer process from the ED to the inpatient area. Data collection will also include some structured interviews with our participants to better understand the patient care team's perception of patient information problems as well. So in terms of the field study resulted in 200 pages of transcribed field notes. And I analyzed this using the 6-phase thematic analysis by Braun and Clark. If individuals aren't familiar with this, this is just a very rigorous process of becoming first familiar with your data by reading through it and transcribing it. And then I identified individual codes within our data. So here's some segments that were to missing information. And then as individual codes, I grouped them into preliminary themes. So in this case, the preliminary themes ended up being the different communication modes that missing information ended up occurring in. And then all of these preliminary themes start to evolve. We group them into final themes, which are defined, bounded. One of our final themes, of course, was missing information, which is a type of information problems. A bit about our results, and then go into a discussion about how this impacts those in industry as well as research. Was to develop a PIP taxonomy. So we're currently still going through the analysis of the data, but here's our taxonomy now. 120 discrete PIPs were identified through all of the field study data, and they were classified into 6 different types. So here's the wrong information, which is simply when information is not accurate, and it's identified as being not accurate. Second is missing information. And this was information that the team clearly stated that they expected it to be there, but it was not there. The third, where only part of the information is provided. And this frequently occurred when they had consulting physicians that came to look at a patient for a particular reason, and at times the progress notes only included certain information, but the patient care team was missing other aspects of that information, such as they recommend treatment or diagnosis or different tests that needed to be run, and therefore they had to follow up with the team. The fourth is outdated information, and this was classified as information that frequently changes and is no longer valid and has not been updated. This also frequently occurred with nurses. So nurses are typically tasked with, throughout the day, gathering vitals of the patient, which includes inputs and outputs, their blood pressure, their glucose monitoring, and any other vitals that need to be monitored for that patient. And since this is done so frequently, they can monitor this and they'll post it in the room using other forms of documentation, but they don't always update it in the EHR system immediately. And so sometimes this is outdated information that the clinical team needs to follow up with the nurse on. This type of unclear information, which is what we categorized as there being uncertainty about the accuracy or meaning of information. So it wasn't the information was immediately identified as being wrong or incomplete, it just wasn't quite clear what was being said. And then the final, segregated information. This is where multiple pieces of related information are stored in different locations and are not easily viewed together. And this typically happened in the EHR system, which we also saw in prior literature, where if individuals needed, for instance, they saw that a medication was ordered, but they didn't know who ordered it or why they ordered it. And so they then had to go into the pharmacy system to look at who ordered it, when it was ordered, and sometimes even have to scan through pages and pages of progress notes to understand why that medication was ordered. Of the data from the field study, I'll give one example of wrong information directly from our field study. So our nurse exited a patient's room, and we had a pharmacist rounding with the team. And the pharmacist told the team that the patient medication penicillamine, and she questioned whether or not this was correct or whether it was supposed to be penicillin VK. So the team gathered around the EHR and looked at the patient's medication list and patient history, and they realized that it was the medication. The patient should have been on penicillin VK, but this wrong medication had been carried over in the stem from the patient's ED admission, and so they had got it. So this was an example of when they identified wrong information. At TAXONOMY, we also looked at what mode of communication was the information problem identified during. So in this, you can see 69% of the information problems were identified when they were at the EHR system itself, which makes sense since this hospital has had an EHR system implemented for over 10 years and its primary source of patient information. It's also interesting to point out that 25% of the PIPs were identified during verbal communication. which was typically face-to-face with individuals or over the phone. And then also identified when they were looking at their handwritten notes that were on paper-based documentation. So from this is that the EHR system is where a majority of these PIs are identified, which further motivates our study to take a look at the design of this EHR system to see if we can better design it to help with the identification and management of PIPs. Okay, so now that some of the PIPs are, I'd like to talk about how these particular patient care team members identified the patient problems. So the ways in which they were identified. The first is they were encountering conflicting information, and this was simply when participants identified a discrepancy between two sources of information. That was when they were making sense of information, and this was when they just questioned the accuracy of the patient's information based on either their medical training and expertise, their experience with other patients, or even the specific knowledge of that patient conditions. So when we're looking at things, something just didn't quite make sense, and so they started to question it. The third interesting, this was when they were generalizing unreliable information sources. And this is where participants actually associated certain hospital units as having a reputation for unreliable sources of information. This was frequently spoken about with the emergency department, just due to how fast-paced the emergency department is and how quickly patients come in and out. Sometimes their documentation isn't always reliable, as well as the surgery ward. A lot of times surgeons' progress aren't always as detailed as a lot of the internal medicine teams need them to be, and therefore they view as somewhat unreliable sources of information. The last one was simply when they were seeking specific information and they were not able to find the needed information. So once again, I'll just give one example from my study. There was a time when an attending during morning rounds was asking a nurse why a patient was getting liquids when the system clearly stated NPO except meds, which means that they were not supposed to be having liquids. So then that the resident had told her earlier that morning that the patient could drink liquids, but it wasn't updated in the system yet. So this was a case where the system was saying one piece of information and the nurse was saying something else, and so they were able to identify that there was an information problem in the system. To quantify these 4 different types of the ways in which they were identified and look at them from the perspective of our taxonomy, our PIP types. And so I'd like to talk about just some of these categories here. The first is not finding needed information. So you can see this was 42% of the time they identified a problem when they were seeking information and they couldn't find it, which makes sense. The significance in this data is that this is only related to missing, incomplete, or segregated data. So it doesn't have to do with wrong, outdated, or unclear information. It was to reminder information that they actually expected to be there. It wasn't information they knew may or may not be updated yet. They really did think that it was supposed to be there based on their conversation. And what I saw in my qualitative work, I was observing them, is that this process of not being able to find information that they needed really did delay their work and a lot of the decisions that they had to make for that patient. So a lot of times they had to table their discussion during morning rounds and have to revisit it a couple hours later when residents were able to follow up with information that they needed. The second area at this table is the honoring conflicting information. This was 32% of PIPs identified this way. And again, based on observations, this frequently occurred when there was communication with other members of the team. So the conflicting information was usually between the system and what somebody else was saying. And this really further exemplifies the importance of collaboration when co-managing patient data and being able to communicate across and having effective communication means across the entire patient care team is so important to identify if there is conflicting information and then go about resolving that information. And one from the IT perspective, we want to see how systems can perhaps better facilitate this process. We also have roles that actually identified the PIP. So we'll say the residents and interns 41% of the time identified it, attending 33% of the time. And this is perhaps a limitation of our study in that we're specifically following these clinical teams. So it's very expected residents, interns, and attendings were identifying these because that was the direct team that I was following that time. But it's also important to note that the nurses did play a critical role. 14% of the time they did identify this. They would proactively come up to the team or call or page the team in order to question them about the accuracy of certain information, especially when we look at wrong information, which tends to be one of the most critical categories in terms of impact impact wrong information on the patient or the workflow. So nurses identified the same amount of wrong information as residents and interns. So this is a critical role that nurses play in identifying wrong information, as well as the importance of all of these teams really double checking with each other and communicating any concerns about patient information. Okay, how they were identified, what did they actually do when they found out there was information problem? And after doing our data, we found 5 different ways in which they did this. They used the problem, which is just when the participant had knowledge as well as the system rights to go into the EHR system and directly fix the PIP. There were times when the participant could not fix the PIP themselves. This was typically due to lack of system rights or that they had to verify information, perhaps when attending or a clinic to make sure certain things were correct. They then had to track down that person in order for them to fix the problem in the system. The third was when they just needed to find out about the PMP. So they had the rights to fix it in the system, but were that around the PMP, which was when they were trying to accomplish an immediate task, and they did need that information, but they found a way to just kind of work around it to get their task accomplished anyway. And during the problem was when, again, they had an immediate task they were working on, and didn't necessarily deal with what they were doing. So they just didn't work and did not address the PIP at that point. And again, this was while I was observing them, which was, from the handoff from night shift up until documentation in the afternoon. So I was not with them the entire day. They may have fixed these later on, but at that period of time when they identified it and during the time of more rounds and documentation, they did not appear to attempt to fix any of these problems. So one of the issues with this, of course, is that it then persists in the system. So once again, an example of this, in terms of finding someone to fix the problem. This was a case during morning rounds that a nurse had to call and page our team in order to talk about patient's vancomycin order. So the nurse talked to the resident and said that he'd ordered the medication for tomorrow, which was a Sunday, but the patient was being discharged that day on Saturday. And so it was confused and said that he thought he ordered it for today. And actually discussion with the nurse about how the system sometimes sets default values for medication administration and that the default value was set for the next day and he forgot to change it. But he did say that the patient needed that medication administered before discharge, so he went into the system since he had the rights to change that, since he put the order in, and changed it for the nurse. So again, this is an example of the nurse identifying that problem and then having to find the right resident to fix the problem. So once they quantified these according to the different ways in which they managed it, and on the PIP taxonomy of the 6 different types. So again, finding someone to fix the problem and finding more information. This actually accounted for 60% of how they had to manage the PIPs. And all of the times it required that they collaborate and communicate with others. So once again, enforcing that the importance of making sure that there are good communication and collaboration tools available to these teams so that they can manage these problems more efficiently. At the time, the PIP was not immediately fixed, and therefore I mentioned it then persisted in the system, and this can potentially affect others who are relying on that information being updated in order to do their own tasks or to make decisions about their patient care tasks. Now I'd like to talk about what some of these results mean. Talk about is the PIP's impact on workflow. So as we saw in our background, a lot of informatics research talks about the impacts, and we wanted to see how our patient information problems that we saw had similar impacts on workflow. And what we saw in terms of how they managed these PIPs was either that they managed it, meaning they fixed it, found someone to fix it, or found more information before it could be fixed, or they didn't manage it at all, meaning that they worked around it or they ignored it. And we found these results, these actions, had an impact on their workflow. So managing PIPs, it typically to additional work. And the specific additional work that we saw was it took a lot of time for them to track down other people. Because it was a very large hospital, at times they had to physically go to other units or page individuals. And in this case, our residents actually didn't have their own mobile phone. So they then needed to find phones if they were paged themselves. And a lot of times they were busy. So it was this back and forth of track people down all day in order to get information. The second additional work was that it required them to search through a lot of sources of information, right? And typically this is due to a lack of integration of a lot of the information in hospitals. So either a different system they had to look in, like the case where if one wanted to understand why medication was ordered, they had to go into the pharmacy system, or they then had to go to another area of the EHR and look through pages of free text that talked about the progress notes and decisions that were being made. So it took a lot of time for them to try and piece together a cohesive view of the information that they were looking for. And going and searching led to a lot of delaying their own patient care tasks, which also impacted the patient. So sometimes decisions about treatments, medications, tests that needed to be run, diagnosis decisions, or even discharge were delayed for hours and sometimes a couple of days if they could not find the necessary information. So this in which managed PIPs was simply by not managing it, right? So they either found a way to work around it or ignored it, and this then led to persistent problems and what we're calling cascading effects on the entire team. And what we saw in our own research, which matches with a lot of what research talks about as well, is it led to multiple people on the patient care team doing the same work because they realized somebody else did it, multiple teams ordering the same test because it's been updated in the system, confusion about the different treatment decisions, whether it was medication or tests or procedure needed to be done to that patient. And this also, from an organizational behavior standpoint, led to a lot of tension and frustration between the units and roles, which also impacted their ability to communicate with one another. If they were frustrated with each other, they tended not to reach out and ask questions, and therefore this kind of hindered communication between the roles, which, as we saw from the findings, communication and collaboration was really a key part of identifying and managing these information problems. So we want to take a look at how some workflow can potentially be helped through EHR design, since our area and focus in this project. So we're still currently going through the data and analyzing it, but I'd like to share with you two of the design recommendations that we're currently discussing in our team. The first concept is decreasing data segregation. So we saw a lot of time spent on trying to piece together information from a variety of different sources. And a majority of these times it dealt with medication or tests or procedures that were being ordered, and they simply just didn't know who ordered it or why it was ordered. So we'd like to look at how we can design an EHR that can link a standardized field, such as what medication was ordered, with this field that is associated with that. So for instance, why was it ordered and who ordered it and when was it ordered? And we in our literature, especially in IT systems used in the medical field, that we can use hover boxes to temporarily display information, right? And this allows users to copy that information if they need it somewhere on screen, or just simply for them to be able to view it and then they can close it. So they're not crowding the screen in any way, just simply giving them additional information when they need it. So to just a brief example of what this might look like. And again, this is just a mock-up, but it's an example of a fake medical record for Buffalo Bear, and he has amoxicillin prescribed to him. And if I'm a resident and I'd like to know who prescribed this and why they prescribed it, because it's not evident just from this part of the medical record, a way in which we can use hover boxes is simply by allowing them to click or have to click on it and allow them to view the order details. This would allow a hover box to appear that pulls information and consolidates it from other areas of the system or integrated systems, such as the pharmacy system, to show who ordered it, even the unit that they belong to, perhaps their pager numbers. They can be contacted if there's additional information that needs to be talked about, when they ordered it and the time, and even their reason from ordering, which typically comes from their progress note. So this then allows them to quickly see it, so that they don't waste time going into other systems and affecting their cohesive understanding of what's going on with the patient, and then be able to disappear when they're knowing that information. So the second design recommendation that we're looking at is flagging these patient problems. So we talked about how sometimes they just worked on it or they ignored it, or perhaps were just talking about it and there were sometimes hours before it was able to be fixed. So this could then lead to persistent problems in our system, and it can affect other team members. So the act of flagging this information would allow immediate recognition of the PIP, and it also provides a visual notification to other team members so that they know if they're trying to make a decision on that information that it's in question. You can provide annotations, offer explanations for why that information is being questioned as inaccurate. I want to show you an example of what this might look like on our record. So if I'm a resident, amoxicillin has been prescribed to Buffalo Bill, and I don't think it's appropriate more. So it's questionable as to why this is still on here. But I'm not quite sure, and I need to follow up with other people. Again, an individual might be able to right-click and add the item. This then visually display to anybody else, such as the nurse who's responsible for administering medication, that this particular medication is in question right now. You could even add a comment that automatically pulls the username and the time and date and provide a comment as to why this is in question. So if not sure that this still needs to be prescribed to the patient, whether it's unnecessary, if their UTI had already cleared and they no longer need amoxicillin on a daily basis. So if a nurse saw this, she could then follow up with whoever left the comment and say, would you like me to still give it to them, or would you like me to hold off? Simple way to help keep the team aware during the process of trying to figure out how to that information problem, and it can also help prevent medical errors from occurring or unnecessary medication or procedures from happening. We're still in the middle of this study. So our next for this is to continue with semi-structured interviews with our participants, and also to better look through the data and come up with more EHR design recommendations like those that we talked about today, in order to provide recommendations to vendors in the design community for how we can better improve the identification and management of these PIDs, the information problems, for the entire patient care team. So listening to my talk, and I'm happy to take any questions or comments.
Amy, quick question. When you're looking at, can you
hear you?
Okay. When you're looking at kind of enhancements or whatever, do the EMRs kind of have it at times out, or can you set, you know, when something becomes stale? So, for example, a blood pressure, those that have to be updated routinely, do they time out and flag as invalid?
My experience in this particular hospital with this EMR, which is the experience I have with EMR, it's listed active information, but typically there is a timestamp. So they are aware with certain types of information, for instance, like blood pressure, inputs and outputs, they're aware of when the nurse last entered the information. So it doesn't really time out. It shows that information, but it does show when it was entered.
Okay. To me, that you'd want to be able to say, okay, blood pressures are good for 12 hours. And at 12 hours, it turns red or it blinks or something, so that it calls our attention to, you know, it being stale. Thanks.
Yes. Thank you.
Well, thank you very much for this great talk. I really enjoyed it, especially because of qualitative research, but that's just myself. Thank you, everyone, for attending today's webinar. Please feel free to either email Alison or myself any questions you might have, and please make sure to join our next webinar, which will be next April 29th. Thank you all. Goodbye.